In Shock 3, we're going to talk specifically about septic shock and using the physical exam and laboratory tools to assess resuscitation. We're going to revisit the models again, the tank model and the equation, and see how in septic shock other things can be happening and what you need to do to assess and look out for other problems. And it's sort of general and vague, but let's start off by talking about sepsis and the different severities of sepsis, and then getting into how you assess someone, whether they're volume down or not, and whether you need to go to the next step, and discussing early goal-directed therapy. This is the thing you're going to see the most of in the intensive care unit in terms of shock, so this is the thing you need to know the most. Let's start off by talking about SIRS criteria and different types of sepsis. Every time you evaluate a patient, you have to assess for the SIRS criteria. SIRS criteria is based on the heart rate, the temperature, the respiratory rate, and the white blood cell count. The heart rate is greater than 90, the temp greater than 38 or less than 36, respiratory rate greater than 20, or a white blood cell count greater than 12 or less than 4. You get a point for each. SIRS is equal to 2 out of 4, and SIRS is the systemic inflammatory response syndrome. It does not mean there is an infection. It means there is some sort of inflammation. And what you want to do is identify everyone who's SIRS positive and then explain away the SIRS. If you go running at the gym, your heart rate and respiratory rate will qualify you for SIRS. You do not need blood cultures, you do not need antibiotics. But that person who has AIDS and a bone marrow transplant and Hep C, who's on immunosuppression for their kidney transplant, does not have the ability to mount a response of fever and leukocytosis. So that person who has an elevated heart rate and respiratory rate may actually be infected. So you have to put SIRS into the clinical context. If they have SIRS, which you can explain it away for something else, they're not infected. If they have SIRS and you cannot explain it away, presume they are infected until proven otherwise. If you have SIRS and a source, that is sepsis. To obtain a source, you're going to get blood cultures, a urinalysis with urine cultures, and a chest x-ray. Every patient, every time, trying to find the infection, unless they're able to give you symptoms to direct you. Don't forget about diarrhea, don't forget about abdominal ascites. Those are there, but essentially every patient you're considering for sepsis or septic shock needs to be cultured up. You're looking for the pneumonia, the urinary tract infection, or bacteremia. And that is important. You do not have to be bacteremic in order to be septic. You just have to be infected. The big difference is between someone who has severe sepsis and someone who is in septic shock. The difference being the dashed line. Anyone on this side of the dashed line goes to the floor. Anyone below the line goes to the unit. And here's why. Severe sepsis is sepsis plus one organ in dysfunction. And that is a cute way of saying low blood pressure. But severe sepsis responds to fluid. This is someone who looks like they're in shock. You give them 2 liters, they bounce right back. Now they're only septic because no organ is in dysfunction. They become simply septic and go to the floor. Someone who has sepsis and one organ in dysfunction, which means low blood pressure, if you give fluid to, and they don't respond, that person is in septic shock. The person who is in septic shock is also going to have evidence of ischemia, that is, tissue necrosis. To assess septic shock, you assess it the same way as severe sepsis. You give fluids. But in the case of septic shock, they may improve a little, but their blood pressure doesn't get much better. You can also presume that someone who has a lactic acid that's elevated, a lactate, is also in septic shock and should come to the unit. The idea here is that you treat all patients who with sepsis or more with antibiotics, fluids, and early goal-directed therapy. But once you get into the unit is where you start needing to use vasopressors, which is why they go to the unit. They need infusion of medications to support their blood pressure. So sepsis and severe sepsis can be treated on the floor with antibiotics, fluids, and early goal-directed therapy. But in order to satisfy early goal-directed therapy for people who are in shock, you need to get them into the unit for closer monitoring. These patients still get antibiotics and fluids, but now they need vasopressor and closer monitoring. You're generally going to get vasopressors and have closer monitoring like an art line. The worst of all of the SIRS stratification is multi-organ dysfunction syndrome. And as the name implies, it's sepsis and the patient is sick as shit. That is, they have got shock liver, their kidneys have failed, they're in ARDS, their blood pressure is not responding. This person is actually circling the drain and has an abysmal prognosis. The septic shock patient is someone who just tipped the edge, and if you scoop them up and put them on a positive trajectory soon enough, can recover. The person who's got severe sepsis or sepsis you've caught very early in the clinical course and you can correct them easily. These are the patients you save in the unit. These are the patients who die. These are the patients who can go to the floor. So with that in mind, let's revisit the equation and the tank method to see how we assess, does this person need more fluid, and how do we assess our response to therapy? Because it's all about early goal-directed therapy. And early goal-directed therapy is about the goals. Your goals are CVP of 10 to 12, a central venous saturation of greater than 70%, a mean arterial pressure greater than 65, and a urinary output greater than 0.5 cc's per kilo per hour. In order to get early goal-directed therapy, what you're assessing is the tank filled up enough? Is there something else other than sepsis going on? Am I adequately perfusing the body? And in particular, am I adequately perfusing the kidneys? Let's put those equations back up and see how that concept applies. Tank's too big. Problems with SVR. Problems with the fluid. Problems with preload. Pumps broken. That's contractility and heart rate. The equation, just so it's there, because we're seeing the elements already in the model. The mean arterial pressure equals cardiac output times systemic vascular resistance. Cardiac output is heart rate times stroke volume. Stroke volume is preload times contractility. We've pulled these elements over here to see how they relate. Now, we've diagnosed someone with septic shock. They had a fever and leukocytosis. Their blood pressure is low. And we want to know, do we give them fluid? Initially, the answer is yes. You're just going to dump them with fluid because someone who's in septic shock is 100% volume down. They have insensible water loss. They're going to have fever, tachypnea, tachycardia, and they're going to lose excess fluid. So initially, don't be timid about giving someone fluid. How much fluid do you give and what type? We'll talk about that in a second. But the question is, after I've begun my resuscitation, have they been resuscitated enough? Do I give more fluid? You're going to generally do two things at once. You're generally going to try to fix the systemic vascular resistance and the preload. You do this because the pathophysiology of septic shock is interleukin-1. The lipopolysaccharides that are contained in gram-negative bacteria are released. They cause a major inflammatory response leading to huge vasodilation. They are volume down in addition. You can just assume that as soon as you make the diagnosis of septic shock. So you know you're going to need to give back systemic vascular resistance with vasopressors. And you're going to give back preload with volume. But then you have to ask yourself, have I done enough? To assess preload, we use early goal-directed therapy. It used to be that the CVPs were considered very useful. Now they're not so much. But central venous pressure of 10 to 12 tells you how filled up the tank is. It assesses the volume on the venous side. If you have a central venous pressure greater than 12, it means that you're overloaded on the right side. You have too much volume coming back to the heart. If you have less than 10, you're dry and you need more volume. It turns out, as we use this more and more, it is incongruent with other assessments. But you can do it without having any other skills. You just tell the nurse, give me a CVP. The person goes flat, she sees zeros in the machine, and the CVP number comes back. So it's very attractive to use because you don't need any other skills. Two other ways you can use to assess whether or not they need more volume are the leg lift maneuver and the sonocyte assessment, that is ultrasound. A bedside sonographic examination of the inferior vena cava tells you if they are preload responsive. That is, you should see the IVC with the sonogram. If you see a fixed, dilated, open IVC, they are filled to the brim. They don't need any more volume. If that inferior vena cava collapses with each heartbeat, as the venous return is sucked in by the heartbeat, it collapses the vessel, showing that they need more volume. If there's a little variation, you're not sure what to do. And generally, you turn it to M mode, record it for a second, freeze it, and measure maximum distension and the most close constriction. If there's a change of more than 20 millimeters, they need more volume. That sonographic exam either requires you to contact a radiology tech or know how to do a sonographic examination. That's challenging, and not a lot of people know how to do this. What everyone can do is the leg lift. You attach someone to an arterial line, continuous blood pressure monitoring. With every heartbeat, you get blood pressure, continuous readings. What you do then is simply place them flat, allow them to equilibrate for about 5 minutes, and then you and a partner lift both of their legs. What that does is send a fluid bolus. The venous that's stagnant in their legs, the venous return increases. If their mean arterial blood pressure increases by 10 on the mean arterial pressure recorded by the art line, then they are fluid responsive and need more volume. So in summary, to assess whether or not someone has been fully resuscitated with volume, you check a CVP, do a leg lift, and look at their IVC. The least reliable of all three of these is the CVP. If the CVP is 20, they're overloaded. If the CVP is 2, they need more volume. But as you get closer to the goal, the utility goes down. Leg lift and sonocyte become the next step. All right, that's for assessing volume. The way you assess whether or not your systemic vascular resistance is appropriate or not is by following the mean arterial pressure and the urinary output. The idea being, if you have enough diastolic tone, your mean arterial pressure should come up. Which is why when you write orders for vasopressors, you say, start this medication and increase until the MAP is 65. Now we know from studies that are done that what we use to replace systemic vascular resistance is, in this order, Levophed. When you've maxed out Levophed, you add vasopressin. And when you've maxed out vasopressin, you give epi. And in all honesty, if you're reaching for a fourth pressor, that is the time where you have a family conversation. People can come back from 4 pressors, and I am sort of implying my own personal beliefs in situations like this, but when you are reaching for number 4, it is time to talk to the family about futility. You can keep adding on pressors, but they probably don't have any utility. Instead, what you should be thinking of as soon as you get to this point, as soon as you start adding on the third, is, has this person been in such an extreme stress response that they don't have any more cortisol and they're actually Addisonian? They may need steroids, and a lot of them, because more pressors aren't going to work if you don't have cortisol, which is why Addison's disease causes hypotension in the first place. They may be so sick that their adrenal glands burned out. There were 2 studies done in terms of the utility of steroids. One said everyone who is septic gets steroids, no mortality benefit. The second study said, let's wait for those people to be really sick. And they said that after 2 pressors, let's start steroids. Those patients, steroids showed a mortality benefit. So steroids are not used in every person, every time. They increase the glucose, they increase risk of infection down the road, a secondary infection, but they also are required if the adrenal glands have burned out. So systemic vascular resistance is assessed by the blood pressure and urinary output, and is fixed by giving vasopressors, and we sort of know already which 3 to use. If you're getting down to the third, start thinking about giving steroids. One of the things we didn't do was say, do we need blood or not? And this is a little difficult to understand because blood is a volume expander, but it also increases oxygen delivery to the periphery. We've talked about mean arterial pressure and urinary output and the CVP, and we've used those to assess the volume status as well as systemic vascular resistance. We have not yet talked about the central venous oxygen saturation. And the idea is this. The heart is a pump connected to a circuit. That's the body. In sepsis, there is huge vasodilation, so that any anastomosis, any AVM that could possibly exist would just open up. So the whole body essentially becomes one giant AVM. The flow through the system is incredibly fast. So whatever oxygen was here, there isn't enough time for the cells to extract any oxygen. They're getting sufficient oxygen because blood constantly flows through, but the amount that gets extracted is very small. So the amount that returns is high. Let's use some numbers instead of percents to illustrate a point. This is not a physiologic system. It's not how the numbers work out in real life, but I want to illustrate a point to hopefully have you arrive at the right answer. Let's just assume that every hemoglobin can only carry 1 oxygen. So if someone's hemoglobin is 8, they have 8 units of oxygen. In this system, they only require a small amount of oxygen for the cells, so their oxygen extraction is 2. What comes back is 6 oxygens on 8 hemoglobins. Percent sat, 75%. Now, let's say the person has a reduced hemoglobin. Let's say their hemoglobin is 4. That means they start with 4 oxygens. The extraction of the system from the cells is still 2. So what comes back is 2 oxygens on 4 hemoglobins, 50%. What this does is illustrate the point that if the central venous sat is less than 70, that they may need more hemoglobin. What you do not do is transfuse past 8. We've done future studies that have shown there's no mortality benefit for giving lots of transfusions. But if the SCVO2 is low and you're thinking, does this person need more blood? Chances are it means yes. So the time you give blood is when they are less than 7, because that's our transfusion threshold for all evidence that we have, or if the SCVO2 is less than 70%. But that SCVO2 may mean something else. If instead of a very fast system that's just flowing fluid through here, you have heart failure, and instead of this system you have a puddle, cells just continue to eat the oxygen in this puddle. So the extraction is going to be huge, because the more time that this blood is in contact with these cells, the more oxygen comes out. So the person who starts with 100%, who has heart failure, pushes blood through slowly through the system, lots of oxygen comes out, and on the other end, the SCVO2 is low. The whole point of this is that an SCVO2 less than 70% indicates something other than sepsis is going on. They may still be septic, but they may need blood or they may need inotropic support to assist their heart. Okay, let's come back to the model and see how that plays in. To treat pump failure, you are going to control the heart rate with shocks or give inotropes. What you're going to do over the first day or 2 is assess tank and fluid. You said they're septic shock, let's give them a lot of fluid, let's give them pressors. If they don't get better, that's the time where you start thinking, wait, do I need some sort of inotropic activity? To assess, are they getting better, you use the SCVO2 and the lactic acid. Because if you have fully volume resuscitated them and they're on 2 pressors with steroids and they still are not resolving their lactic acidosis, their SCVO2 is still not getting better where you want it to be, that might be an indication that they have some contractility issues. So you're going to look at their hemoglobin and give them some blood if they need it, which is more volume support, or you're going to start them on an inotrope, an inodilator like dobutamine or milrinone, in addition to your vasopressors. That last step, understanding the SCVO2 and starting an inotrope, an inodilator in the setting of septic shock, is extremely advanced, and you're probably not going to make that decision on your own. What you should really focus on in this lecture is early goal-directed therapy. How you assess whether or not you need to give steroids, and that is the mean arterial pressure is not cooperating with your vasopressors, and do you give more volume, that is using the leg lift, the sonocyte, and the CVPs. Often you're making these decisions at the same time and trying to fix them at the same time. In particular, these two go together, and then only after some time do you give consideration to pump failure. That's the takeaway. Use early goal-directed therapy and the techniques involved in order to determine if your resuscitation is adequate. Not on early goal-directed therapy, but very important, is the lactic acid. And the caveat here is that lactic acid does not mean sepsis. It means tissue necrosis from poor perfusion for any reason. And in this setting, the lactic acid should adjust towards normal if you're fixing the systemic vascular resistance and preload. If it doesn't, it means that your assessment so far has been inadequate, or you need some pump support. One last final caveat, and this will come up in GI bleed as well. If you're going to give someone fluid, people have a resilience to lactated ringers in medicine. The reason why normal saline is chosen in medicine is because it contains no potassium, and our patients may have renal failure. Often we give very low volume normal saline resuscitation, 1 liter bolus, 500 cc bolus throughout the day. So most of our patients get normal saline. The reason why surgeons like lactated ringers so much is because they bolus 10, 12 liters in the course of a bad surgery, or someone who has complications or in order to support their blood pressure while they're hemorrhage. Their patients generally have good kidneys and the potassium doesn't matter. If you bolus large amounts of lactated ringers, the risk is hyperkalemia. There are 4 milliequivalents of potassium in each bag of lactated ringers, so that if you give 10 liters of lactated ringers, you give 40 milliequivalents of potassium, what we give every day to our patients who are asymptomatic hypokalemia. If you give 10 liters of normal saline, you cause an acidosis. The pathophysiology is not worthwhile, but you worsen acidosis and worsen coagulopathy. In the setting of sepsis or in shock, where you're going to do a large volume resuscitation, I will tell you that it is better to use lactated ringers, understanding the small risk of hyperkalemia, than it is to give large volume of normal saline, which will make their acidosis even worse, because these patients are going to have a lactic acidosis. So takeaway points from this lecture. Follow early goal-directed therapy to fix systemic vascular resistance and volume resuscitation first, then give consideration to pump failure or blood. Know when to give steroids, that is, when 2 vasopressors have failed. Finally, when you give large volume resuscitation, use lactated ringers. That is shock 3, septic shock.